Hello, Dr. Shilpa McQuillan. Welcome to the Menopause Research and Education Fund. We are talking today about recurrent UTIs and chronic UTIs, which is an important topic when it comes to perimenopause, menopause. But before we get to that, let me give you a quick introduction. You are a women's health GP, a community gynaecologist, a menopause specialist with the BMS, and also the founder of the Berkshire Menopause Clinic. So you clearly have dedicated your whole career to women and women's health. When we get around menopause, why is it that we seem to find that we have more recurrent UTIs or more UTIs in general?
Yeah, really good question. So a couple of reasons is that there's people who get recurrent UTIs that then becomes chronic UTIs. So obviously the older you get, you're going to present with them more often and obviously then have them for longer. But also the other reason is that decrease in hormones, that fluctuation in hormones and eventually decrease in hormones, in particular estrogen. So estrogen's function is so wide, and I could talk about this all day, but just to describe that our estrogen we think of, don't we, as predominantly being in the vulva, in the vagina, but actually it's also presented in the bladder and in the urethra, the opening to the bladder. So there's two reasons this happens. It's a functional thing because of the urethra and bladder estrogen that declines, but also a lot of women or people don't realize that most postmenopausal or perimenopausal UTIs or urine infections that occur are actually coming from the vagina, because the vagina and the bladder are in very close proximity. So can I just get my model for you just to show you? So this is my vulval model. I hope no one's going to be frightened, but this is our clitoris. This is our urethra, the opening to the bladder, which then leads to our bladder. And this is our vagina in here. So we've got estrogen receptors here in the vulva, all around the clitoris, but we also have them in the urethra and in the bladder. So you can imagine if you've got lack of estrogen, and we'll talk about this in more detail around the vulva and vagina that's decreasing, and there's increased risk of infection in the vagina, then that is in very close proximity to the urethra, so bugs can get there. But also if we've got decreased amount of estrogen in the urethra and in the bladder, this can have structural function, reducing the ability to hoard off bacteria that can form in there as well.
So are there, in some ways, are there two things going on? With a reduction in estrogen, are we talking, does it cause a change in the acidity so more bacteria can grow? And with the structural changes, are there also structural changes that involve weakness of the muscles and things like that that would also make it difficult for you to empty your bladder properly, so you end up with more urine just sitting there that shouldn't be there?
Absolutely. So estrogen has so many functions. If we think about it, it helps with our collagen. It helps with our elastin, our skin integrity. When that breaks down, what happens is the skin becomes very thin. There's no barrier to infections. We get cuts, don't we? We get that real friable skin tissue. So normal bacteria that would be held outside is a good, easy penetration to get in, both through the urethra and through the vagina, which, as I said, if the vagina is in close proximity and you're getting infections in the vagina, very easy for them to get into our urethra and in our bladder. That's one thing. The other thing is the musculature reduces. That's why we get things like prolapse. We get uterovaginal prolapse, but also you can get urethral prolapse. So a lot of people don't realize that your urethra, the muscle can prolapse, and obviously that comes out and then there's more risk of infection. The other thing is the muscle of our bladder weakens because we've got estrogen receptors in our bladder. If our bladder's weakened, we are not tightening and holding our urine as well, or we're not emptying the bladder. We need our bladder to empty, to get rid of normal bacteria. If our normal bacteria isn't emptied properly, it sits in there for ages. And that means then it puts us at more risk of infection. The other thing that estrogen does is it promotes glycogen. Glycogen promotes glucose, which is converted to lactic acid. Why is that important? We need an acidic environment in our vagina to hoard off bacteria. So it's keeping that at bay. If we lose estrogen, we're not getting that lovely acidic pH.
That's an interesting question. Let me ask you a quick question, because people get very upset about lubes or moisturizers that have glycogen in them. It's like, it's a thrush bomb. It's going to turn you, if you put anything with glycogen in it anywhere near your vagina, or you're going to end up with a horrible case of thrush, because it feeds the bacteria, the thrush. But does it then, in what you're saying, you probably need to have a certain amount of it then to make sure that you've actually got enough lactic acid to keep everything in check?
Absolutely, but that's very different. So synthetic, moisturizers, lubricants, sex toys, all that contain artificial elements, and also things like glucose and sugars is very different, because what happens with those is two things. It increases the pH, so then we're getting more infections like bacterial vaginosis and thrush. But bacteria love sugar. It's a great thing to feed on, which means that they stick to that sugar and then increase the risk of bacteria. So that's why it's really important that if you're choosing lubrication, if you're choosing moisturizers, to have a neutral pH, because what you're also thinking about, it's not just the presence of glycogen, it's having that good bacteria, and the flora has to be, you want a good ecosystem in there. You want the predominant to be good bacteria. Remember, all of this does live in harmony. We all have candida. We all have some pathogens, but it needs to be in balance where your good bacteria is more than that to have that balance. So that's really, really important. But the other thing is what estrogen does is it lowers that pH. So it's helping maintaining good bacteria, because good bacteria needs a low pH to live as well. And that good bacteria is predominantly something called lactobacilli. So you can have candida, you can have some bad bacteria, but we need predominantly lactobacilli. So when you start increasing sugars, that pH, if you think about that pH is sitting there nicely in the acidic range, it goes towards the alkaline range, and then that good bacteria starts to decrease, and then you can't fight off the bad pathogens.
Tricky one, isn't it? It's a balancing act. So
balance, yeah.
Yes, exactly. So when we come to that sort of point, we know that there was a study that was done, I can't remember where it was, I think it was in America now, that showed that topical estrogen was really effective at reducing UTIs. So, in fact, I think it was a 53% reduction in recurrent UTIs over the period of time that they were testing it. So why is this not more commonly available and handed to people pretty much as soon as they hit menopause or even post-pregnancy?
I think if we think about, when we think of urine infections, it's always traditionally thought of as giving antibiotics, hasn't it? And retrospect is a very good thing. If I give an example, sitting in a GP surgery when you're a duty doctor and someone calls you for a urine infection, your go-to is going to be, well, let's treat the acute urine infection. It's not till you look back and see, well, actually, this woman is perimenopausal or postmenopausal, and they've had about 5 or 6 urine infections. They might temporarily work with a bit of antibacterial, or they might not work at all. How about thinking about what is the cause behind this? So, our go-to is to treat the acute infection, but also, is it that well known that actually estrogen deficiency causes urine infections? Because we know it causes some symptoms, don't we? We know it causes can cause prolapse or contribute to prolapse. We even know it can cause urinary irritation. But do many people know that actually you get positive urine infections with lack of estrogen because of all the reasons I've just said?
Clearly not. And then it also comes to the question about, how, at what point do you suddenly go, oh, hang on a second, you probably need to be referred on, or you need to have x-rays. You sit there, you were saying before somebody comes in, you have to look back. At what point does it flag up that you'd suddenly go, oh, hang on, this is a recurrent person?
Yeah, a really good question. So the technical answer to that, if you have 2 or more episodes in 6 months or 3 or more in a year, that is flagged as a recurrent UTI. But you need to think about that individual person. So many women get urine infections. Many women get urine infections, especially younger age. It tends to be different reasons. As I said, postmenopausally, it tends to be estrogen deficiency. Younger age can be more, obviously everyone's individual, everyone's different, but can be more to do with hygiene. And I don't mean someone's unhygienic, but, the way bacteria sits around the bottom, so how we wipe when we go to the toilet. Post-sex, you can get irritation. There's lots of underwear, lots of different things that can contribute. But it really depends on that, basically. So recurrent UTIs, that's the definition, but you've got to think, actually, if someone's postmenopausal, getting even a couple of urine infections, could it be something else? But we have to be safe, because we've got to think, yes, we're talking in what we're doing today, we're talking about estrogen deficiency menopause. But we've got to remember there's lots of reasons that you can get urine symptoms, including things like bladder cancer, renal cancers, and that needs to be ruled out. So if someone's getting recurrent urine infections, yes, I will absolutely think about vaginal estrogen, but I've also got to be thinking, who is the person sitting in front of me? Do we need to be ruling out something more sinister? So coincidentally, I may start vaginal estrogen, but I may be thinking about urology referral to see if they need a camera test, a cystoscopy to look into the bladder as well.
Yeah. And the other area that most people don't think about with this is post-pregnancy as well, isn't it? When you're breastfeeding and after your estrogen levels drop, and that it can be quite common then as well, can't it?
Really common. And this is something I say to people all the time. And in the articles I write for a newspaper, I've written about this, is that anyone with estrogen deficiency can get genitourinary syndrome. And that includes post-breastfeeding. It's so common to get vaginal dryness, recurrent urine symptoms, and actually giving topical estrogen can really help in those situations.
Yeah, it's a really interesting area. The other thing that we often find with these areas is, of course, when the market sort of springs up and various products come on, but there are some that have some sort of reasonable sort of, well, they're common. And what do we know about them? Actually, I will rephrase that. D-mannose and cranberry juice. Are they good at preventing? Are they good at treating? What do we know about them?
Yeah, really good question. So what I would say is any product you look at, make sure it's from a reputable source, because there are products that are, remember, there are supplements that aren't necessarily rigorously tested or monitored by the Drug Safety Association, are they? So you need to be careful where you're getting the product, but these products absolutely can be useful depending on the amount of product in them and the type of product. So if we take cranberry, for example, why is it that cranberry work? Now, we used to think it was cranberry juice, but it's not cranberry juice, it's cranberries. And what's the reason? Because it contains something called proanthocyanins. And we need that in abundance for it to work. So I think it's very variable. I've had patients who say to me, it doesn't work at all. I've had patients who swear by it. And I'm actually wondering if that variability is actually the source of where you're getting that cranberry product and whether the amount of that product is enough. Why does it work? Because what that does is it stops bacteria sticking to the bladder wall. So that's how it works. It tries to line it to prevent it sticking to it. So absolutely, that is one solution that can really be helpful. D-mannose is a sugar. Now, this is where people are going to be thinking, but you've just told us not to have sugar. So when we're talking about the bladder, what happens is when we consume sugar, when we eat sugar or drink sugar, that can be broken down and it gets broken down into the bladder. So you've got all this sugar. Now, what happens then? Bacteria will come and they'll want to stick to it. And that's why we then get the increased urine symptoms and increased risk of bladder infections. What D-mannose does is it's a sugar compound, but it doesn't break down. So what it allows when it reaches the bladder, the bacteria will stick to it, but then it gets flushed out. So it's taking away all that bladder. It's not breaking down in the bladder. That sugar is being excreted out of the bladder and it takes with it those bacterial pathogens.
Very, very clever. And again, actually, I don't know anything about D-mannose really. Is it a drink? Do you have to have liters of it? Does it matter how much of it you have a day? Or how does it work?
There's different preparations, but the most commonest you can get is a tablet form. So I think it's generally one a day that you can take of the tablets. There are different doses, but again, everyone's individual. Some people do very well with a standard dose. Sometimes they have to take a couple of tablets. Always read the packet, because as I said to you, different companies produce different strengths as well. So one tablet could be a certain dose in one company in another, but it's about making sure the purity as well of the product. As I said, make sure you are choosing reputable companies that have been tested or at least have been looked into. But yeah, D-mannose works, for a lot of women. And in answer to your question, it's more prevention. We know that cranberry juice can help. It does help symptom relief in some people, but generally it's preventing.
Yeah. So basically, what you'd have your antibiotics and then in between, just make sure that you continue to take these other things to help keep it at bay.
Yeah.
That's yep.
Now, antibiotics is wonderful for many people, but we've got to remember that we've got drug resistance going on. We've got, we do a lot with gut microbiome, don't we? And it really does disrupt our gut. So what I really want to highlight today, if any take-home messages from me, is that we need to be thinking about other things. Could this be something that needs estrogen? Could this be something that our lifestyle, are you eating or drinking lots of sugary foods? Are there things, that we could be doing better to try and minimize the use of antibiotics? Now, this isn't me saying don't have antibiotics, because they really do have a place. But there are many people, as we know, and in older populations where we've got a UTI rate that, is quite a significant increase in mortality rate, in nursing homes. You and I have talked about that, about nursing rate UTIs, but in general in the older population. But we know that gut dysbiosis in older populations also can be fatal. You can get generalized infections, and if we can try and prevent antibiotic use where they're not needed, that's where it's important to look at these alternatives.
Yeah, absolutely. And the other thing too, I guess, about the antibiotics is also that not everybody finishes their course, and there's also an argument that people, well, you've got a UTI, so here's 3 days worth, and then people will say, well, 3 days worth isn't really necessarily enough to actually get rid of the infection. So there are other things that sort of feed into resistance, I guess, really in the end.
Absolutely, and this is really integral. One, if patients don't finish their antibiotic regime, can cause that. But the other thing a lot of people don't realise is when you have recurrent UTIs or chronic UTIs, you have a level that tends to sit below the threshold that is often, when you dip, you often see on the dipstick. So when we do these dipsticks and we say it's normal, we don't realise actually those with chronic UTIs tend to have a level that's below that, and they do actually have UTIs. These patients tend to need longer courses. So when you go 3 days, it doesn't cut it. They might get some symptom relief, but they tend to come back. What you end up doing in that situation, though, you're in a 10 times worse situation, because those bacteria have grown and grown and grown and grown. And it's a lot harder to get rid of. So you're then kind of fighting fire, because you're trying to get on top of an infection by now that has gone 2 weeks, as opposed to just a few days being there. So in these patients in particular, it's really important to know if someone has chronic UTIs, then have a think about if they have a negative dip, is it really negative? Could they have an underlying low line? But also, even if it's positive, should we be giving more, like a 7-day course extended regime in the first place, rather than three-day course?
Yeah, it's a really interesting one, that. And just as a little aside here, my husband nearly died of septicemia because of a urinary tract infection.
Gosh.
And it was in COVID. So the first night when I sort of sent him into hospital, they pumped him full of intravenous antibiotics and then sent him home. And then the second night he went into a very nasty delirious state with a temperature of 41 and was convulsing on the floor and everything. It was really quite awful. So I called the ambulance, sent him back to the hospital, and they did a dipstick, and they said, you don't have an infection. And I'm on the other end of the phone going, he's septic, for God's sake. But the dipstick didn't show anything at all, which leads me then to the question then is, if you are one of those sorts of people that does have recurrent UTIs, and you go in and you have a dipstick test and they go, no, you're fine, go home. How do you advocate for yourself to say, well, hang on a second, I might actually need this to be cultured, or what's the next step to actually be saying, I know I've got this?
Yeah, it's really, really tricky, because people with chronic UTIs may have that constantly feeling uncomfortable, or, you might even get times that you get positive dipsticks, positive cultures, but then sometimes neither are positive. So, even those who dipstick in chronic UTIs, we have very clear cut, nice guidance. But I think the thing with guidelines, they should be, there's a place to follow them, but you also have to think about, in certain situations, if you've got someone constantly coming with urinary symptoms, as I said to you, safety number one, make sure there isn't something more significant or worrying underlying, and make sure they've had a urology referral and that's all followed up. If that's all been done, but you're getting someone who's just constantly having recurrent UTIs, then think about sending it for culture, absolutely, even if they've got a negative urine dipstick. But even in those with a negative culture, as I said, it doesn't mean you haven't got that underlying infection. But what can happen as a result of that is you can get underlying cystitis, chronic cystitis. So cystitis is inflammation. It's not necessarily infection. But if you think about, if you're causing constant trauma with bacteria trying to get into the layers of your bladder, you're going to get chronic inflammation, aren't you? So you can get chronic cystitis, chronic inflammation, and then things like interstitial cystitis as well. So chronic bladder cystitis, so chronic bladder inflammation that can occur.
Which must be hell to live with. It must be hell to live with that. I mean, it must just be, the chronic pain would be awful.
Yeah. Because in these people, either the urine isn't shown as infection, so they don't get that treatment, even though some people do respond to that, or they're not responding to antibiotics, and it's basically where all the layers of the bladder have become really traumatized.
And how do you come back from that once you've got to that? I mean, A, well, obviously you want to avoid it by not having recurrent UTIs, but B, once you've got to that sort of point, how do you come back?
Yeah, so this is where it's really interesting. So obviously some people, there's a place of using, for example, some people might have prophylactic antibiotics, mightn't they? As a, I was saying there is a place for antibiotics, and some people do very well. For example, having 6 months of a low dose antibiotic at night can sometimes help. Some people get urine infections at certain times. So some people get it post-sex. So obviously making sure that you pee after sex. But again, some people do well at after sex having a antibiotic that can help. That can often help. Lifestyle plays a huge part. And this is where I was saying to you about things like be careful when you choose lubricants and moisturizers. The vagina does not need douching. The vagina is self-cleaning. And a lot of people don't realize, they still think that you'll get more infections if you don't clean the vagina, but you're more likely to get infection by cleaning the vagina because you're getting rid of all the good bacteria and reducing the pH. So doing simple things like that, reducing things like sugar intake, caffeine and alcohol are stimulants of the bladder. So they irritate the bladder. Fizzy drinks, these are all stimulants. So reducing things like that. Comfort things are things like not wearing tight underwear, because again, if you wear tight underwear, it's that nice moisturized environment, good for bad bacteria, things like that. So, but some people that they think that works, some people don't. But with other things in terms of medication, if you're getting recurrent or chronic UTIs, it's about preventing those from happening. And that's where lots of other treatments can come into play. So there's so many new treatments now. There's things that work on, if you're known to get recurrent urine infections, the most common type of infection is E. coli, because that bacteria, E. coli, lives around the anus. And the most common, because from our anus to our vagina and to our bladder opening is not far, then that travels. So there's now immunity, so building up our immunity, so doing things like vaccines for things like that are on the market. So that can be really helpful. There's things like Hiprex. I don't know if you've ever heard of Hiprex. Have you heard
about it? Yes.
Hiprex. So again, this is a really good treatment that's come out and works for many people because it's an antibacterial, but it's not an antibiotic, which means that you don't get drug resistance with it. Now, Hiprex works in two ways. It's got what's it called? Sorry, beg your pardon. Hippuric acid. So we need an acidic environment for this medication to work. So what that does is it keeps it acidic, but then you've got the other part of it, the methionine, and what that does is it hoards away the bacteria as well. So the two work together. And again, it's about protecting those layers. So what it does is it converts to formaldehyde, that methanamine, and it stops the bacteria, basically. So it's an antibacterial, but it's not an antibiotic, so you don't get the drug resistance. So that is used as a preventative treatment for many women to try and reduce the amount of recurrent UTIs you get. Vaginal estrogen was the other one we talked about. The cranberries, the proanthocyanins, that was the other thing that we talked about, all the lifestyles. And then there are things, as well as the vaccines, that urologists can talk to patients about. Where I was saying you can penetrate the layers and cause chronic damage to the layers of the bladder wall, there are things where you can call what we call bladder installation. So what that means is you, like a catheter, through a catheter, you insert fluid and it basically lines the bladder to try and protect the layer, the gag layer as it's called. And again, to try and make it impenetrable, to stop bacteria having easy penetration into the layers of the bladder.
Okay. Does it last long, or do you have to have it done?
So you have recurrent treatment. So, for example, you might have a 6-week, 9-week treatment where you go every week and have that done.
All right. And then in theory is that it will recover enough so you could stop and then you'll have a healthy lining of the bladder.
Yeah,
the starting over. All right, that makes sense. It's quite clever. The other thing that people talk about a lot, and you mentioned before about certain types of lactobacilli and those kinds of things that live in vaginas. Probiotics. We're often told that we should be either eating them or putting them in areas where the sun doesn't shine. What do we know about how effective they are?
Yeah, probiotics is what I would say is, in theory, brilliant. In practical, we still got a little bit way to go. And the reason is that so there's two things we've got to think about and not to get mixed up. There's probiotics for the gut. When we take things orally, it gets to the gut very easily, doesn't it? We have lactobacilli in the gut, so there's good bacteria, and we want a diverse flora in the gut. The difference between that and the vagina is we want lots of lactobacilli in the vagina, but we don't want a diverse flora of bacteria. We want predominantly lactobacilli, which is the good bacteria. Now, if you think about it, when you take a probiotic, and again, it's variable, isn't it, in how people respond to it, but even gut-wise, not everybody says it works for them, but it quickly accesses the gut. But if you think about the vagina, if you're taking something orally, not only has it got a long way to get to the vagina, it's got to stay in the vagina. Also, what type of lactobacilli? So the types are very different in the gut and in the vagina. And the ones on the market, the types of probiotic, tend to be the ones that are actually predominantly in the gut. So not only are we getting enough reach in the vagina and stay in the vagina, is it the type of lactobacilli that we actually want? And is there enough of the strain in there as well? So in theory, it's great. One thing I would say is if you are going to go for a probiotic, go for something with GR1. It's called lactobacillus GR1. Now, this is predominantly in the gut, but there has been some evidence, some papers that GR1 does work if you take it, and it does pass through into the vagina and does help, because there has been showing some good studies that actually that does work. But we still have a long way to go, because we really need the predominant lactobacilli that are available in the vagina. We need that to be getting to the vagina. And also, we're not applying it to the vagina either. Predominantly, we're giving it orally. So we need to work on methods that can do that.
Yeah, I mean, I think there are quite a few suppositories that seem to be popping up all over the place these days. But again, I don't know who's really making them. And
are they enough of and are they the right lactobacilli? And if you think about traditionally, we were told, weren't we, dip our tampons in yogurt, do all of that. Now, again, is that the right type of lactobacilli, or is that lactobacilli predominantly in the gut? That's the other thing. So these products we have to look at, because they're very, very, there are thousands of species of lactobacilli. So just saying to someone, great, that product that I've bought is, costs £500 and it's got lactobacilli, but is it the right type, and is there enough? Because we need thousands of them for that to actually get to our vagina and stay in the vagina.
Yeah, yes, it's I lived in the Soviet Union for a period of time, and as a reporter there in the late 90s, in the early 1990s, and at that stage there wasn't a lot of medicine in the country, and I can tell you now, having thrush in the Soviet Union was not fun, and those kinds of things of dipping yogurt tampons into yogurt, or vinegar in the bath. I did find a little bit of vinegar in the bath actually did help.
Okay.
Yeah, but it was, you didn't want to be there, really. There were other places that would have been better at that stage to be in when you had those kinds of things.
But what I'm providing you is the evidence, but don't forget everything's individualized care. Some people get symptom relief from these things, don't they? So all I'm saying is know what the evidence is, keep that as your gold standard. And if you find some things help with your symptoms, absolutely. But just make sure if you're buying products, you do your research about, are they reputable? That's mainly what I'm trying to get at.
Yes, exactly. We talk about going from a recurrent to a chronic. Is there, and also the availability of vaginal estrogen, and especially when it comes, and you mentioned nursing homes before. Looking very quickly this afternoon at a number of studies, there's literally an 18% death rate from urosepsis in the UK. And that's quite a lot of people, basically almost 20% of people can die from this. Do we need to be, for older people in nursing homes, making sure that they've got better access to vaginal estrogen? I get a lot of questions from people for saying, my mum's in a nursing home and they want to stop her vaginal estrogen. How can I stop them from doing that? How can we flip this around to actually sort of say we're actually going to save people's lives in a nursing home by doing this?
Yeah, I mean, it's a really good point. That's education. There's one aspect of not realising someone's got a UTI, firstly, because if you think about people that are in a nursing home, unfortunately, there's a huge amount of people with Alzheimer's, dementia, and they're not necessarily, or other conditions. They've had a stroke, or many communicative conditions that many patients have, that they're not able to communicate what their pain is or what their symptom is. I can tell you if I've got burning when I pee. Not everybody can do that. So it's working out what the diagnosis is, firstly. Secondly, what about the fact that when you have a UTI, are they getting the correct treatment? Like we say, are they getting antibiotics or are they getting vaginal estrogen? And then the third issue, which is you're bringing up, is why is it being taken away? Where's that data to say it's unsafe for that patient to have it? Because actually, we know that vaginal estrogen is safe. We give it to many patients who, even where systemic HRT might not be the first line that we would advise patients, but we know it's safe. But also, are we increasing their risk of UTIs and urosepsis and mortality by taking it away? Absolutely. So the answer, you and I both know this, is more education. And hopefully people will listen to this. More of our colleagues or more of my colleagues will listen to this and hear, actually, have I thought about UTIs when I've thought about? And if I have I thought about that person really is antibiotic recurrent use appropriate? And is it actually working, or do I need to think about things like vaginal estrogen? And absolutely, I do not need to be stopping vaginal estrogen. I'll say this to you, but I'm very, very careful the way I say it, but I do say to women in a very polite way, you can take it to your grave. Do not let anyone take that vaginal estrogen tube away from you, because there's absolutely no reason, because we're not only trying to reduce symptoms you've currently got, we're trying to stop them getting worse. And many people, they recur and they come back if you stop estrogen. So there's just no need to be taking it away from people.
Actually, that's an interesting question. What do you think out of that? One is that prasterone or Intrarosa, which is the DHEA alternative to an estrogen cream, does that have the same evidence for it as well when it comes to preventing UTI?
So, yeah, Intrarosa is still quite new, isn't it? We know I've got lots of patients who do really well with it, and they swear by it. And there's lots of reasons we can use it. We know that we can't. There's not enough studies say to use it in active breast cancer, but even people who've had breast cancer, we can use it. And there's been good response to it, both urine symptoms and obviously vaginal and vulval symptoms as well. So absolutely, it can be given as an alternative. But what we've got to be telling ourselves is, why are we using it as an alternative? Why would you not be using vaginal estrogen? I give DHEA, I give Intrarosa, but some people need both. Some people have it as an alternative. But you've got to be also thinking what are you doing while you're doing it? Why are you not offering somebody vaginal estrogen as well?
Yeah, it's an interesting one. Are there other things too? We often hear that you've got to drink vast amounts of water. You mentioned wiping your bottom from front to back, those sorts of things, peeing after sex. Are there any other things that people can do to, reduce their risk of recurrent UTIs?
Yeah, as I said, like all those lifestyle things we've discussed. So peeing after sex is a good one. Think about your sex toys. Think about your lubricants. These are things like sugary products, artificial products, absolutely. Type of underwear, cotton underwear. We often describe, is your underwear making you unhappy? That's how I describe it, because is it making you depressed? Because actually it can make a huge difference. The rubbing, the moisture, the tightness can make a huge difference.
Leggings. We all live in leggings these days. Well, yeah. I know I do anyway.
I do as well. Yeah. But, sometimes that can be more comfortable than tight trousers or jeans and things like that. Let's not forget other simple things, though, as well. Let's not forget about ruling out STIs, and anyone can get an STI. Let's not presume somebody, because they're a little bit older, doesn't have a STI. They might be newly partner sexually active. Let's not presume it's the typical population.
No, a study that came out from Australia a few years back on nursing home residents, and the STIs were rife. They were having a lot more fun in there than probably most of us out here are.
Absolutely, and so we need to. Let's think simple is simple. So as well as doing all these lifestyle reduction, now vaginal estrogen, thinking about the UTI treatments, rule out those things that are sinister like bladder cancer. Rule out things like STIs as well. Because these can all present quite similarly in their symptoms.
If you have bladder cancer, can you use a vaginal estrogen?
Yes, you can use a vaginal estrogen, but obviously we need to be ruling out, because we know vaginal estrogen isn't systemically absorbed. Even people with endometrial cancer, we know that we can use vaginal estrogen. So similarly, must present with bladder cancer. But obviously, we know that some cancers are hormone receptor positive. So I'm not sitting here blasely saying someone who's at very high risk of cancer, anyone who's an oncologist sitting here going, well, she's just promoting use of estrogen. I'm not saying that. We need to investigate it properly, but we know that vaginal estrogen is minimally systemically absorbed, don't we? So, but if you've got a positive estrogen receptor cancer sitting close by, we do need to be cautious. And I would say, speak to a specialist, a menopause specialist, speak to a urology specialist, in combination. When I see these high-risk patients who've got cancer, I will do it in combination with an MDT approach, multidisciplinary approach, with their oncologist or with that specialist as well.
Yeah. Now, there's another important question. Can you bring your model back?
Yes.
Bring that vulva back here, baby. A lot of people will say you can only use your what was called Avesta, now estradiol cream, internally in the vagina. However, many others will say you do have, as you mentioned before, those receptors all around the vulva there. Some people will say, make sure you put a little bit around the opening of the urethra. Does that help?
I'm really glad you've done this. I've just done a post on Instagram. I haven't posted it yet. So whoever's listening to this are the first to see it. I've just done a post showing how you should be applying it everywhere. Vulva, vagina, urethral, clitoris, all of this area. Because as I said, there's estrogen receptors here. There's estrogen receptors in the bladder. Absolutely, the vagina is where estrogen receptors are as well. So that's why getting to the source is useful. But if we're saying there's receptors here as well, just putting it in the vagina isn't going to help. We need to be rubbing it here so that there's some ascent into the bladder. So absolutely, I tell women, and in my letters, everything where I instruct people how to use it, that's what I'm telling people.
Yeah. And is it worth then people grabbing hold of a little mirror and just having a little look to see whether that they can actually see where their urethral opening is? And also, of course, then, to check for anything else like, lichen sclerosis, changes in colours of skin and all of those sorts of things. It's interesting because I remember once one person was saying to me, there's absolutely no studies that show there's any benefit from examining your vulva. And I kind of thought back and I thought, well, hang on a second. We used to say decades ago there was no real evidence of examining your boobs. But now we do realise.
Okay. I'm very, very passionate and clear about this. If you don't know your anatomy, and especially if you think post-COVID, when there's a lot of telephone calls, how can you explain to a healthcare professional where your symptoms are? Now, I do a lot of talks for healthcare professionals on this, where it's so classical. Somebody phones and says, it hurts when I pee. Now, this is one of those classical. How many people do you think see them and they get urine infection antibiotics after antibiotics? Now, if you get to the crux of it and it hurts when they pee, but actually what they're actually telling us, when the urine hits their vulva and there's a patch here that's stinging, but they don't know that is actually their vulva, and that doesn't mean it's a UTI. It could mean a potential vulval cancer. If you don't know your anatomy, how do you relay that?
Yeah.
If you're telling someone, I've got vaginal dryness, right? Your vagina is in here, it's not here, but really you're meaning vulval dryness. How are you going to get the correct treatment where you're told to apply it around your vulva, vagina, and also, I've got vaginal itching. Well, that might mean you've got thrush. Go and get some thrush treatment. But actually, if you've got vulval itching, and that means you've got lichen sclerosis, you've got lichen planus, you've got a cancer sitting on the vulva, and you're on the phone telling your GP, I've got vaginal dryness, vaginal itching, go and get thrush medication. That thrush medication is not going to help that little SCC sitting there, that cancer, is it?
No, you might get a couple of days worth.
It's integral for us to know our anatomy. To relay to healthcare professionals, but also I want to know what my anatomy. I mean, I know I'm a gynaecologist, but I want to know what my anatomy is so that I can know that it's healthy, because only you know your own body, and we are all very different. If you look on reputable, obviously, please don't make a mistake of getting yourself done by the porn police. But if you go on a reputable site, everyone's vulvas are different. But how do you know yours has changed, or what those changes are, if you don't know your own anatomy? Because what mine looks like and yours looks like will definitely be different. But what's more integral is not what I know what yours looks like, it's what I know mine looks like in the first place. So if it changes, I know what.
Yeah, you've got to know your normal, haven't you, really? Yeah. Brilliant. Is there anything else that you would like to add? Take home
I think we've covered quite a lot, haven't we?
I think we have. Yeah, we definitely have. Yeah. We no more. Cut back on the sugar and the what do they call them? Carbonated drinks. Make sure you're well hydrated. Get your vaginal estrogen.
Know your anatomy.
And you'll be pretty.
Be careful of products. Do your research when you get products.
Yeah, brilliant, excellent. Thank you so much. Now, if people want to find you, where do they find you?
Yeah, so I've got a website and I've got lots of free resources. I write all my own leaflets. I also write for a newspaper. I do podcasts. So it's all on my website, www.berkshiremenopause.clinic.com. And I've got lots of resources. And obviously, if people want to find me as a specialist, then again, go on the website.
Brilliant. Thank you so much. And hopefully we will speak to you again sometime soon.
Yeah, lovely to speak to you. Thank you for having me.